Evidence-Based Practice, Preventing Intraventricular Hemorrhage. Next slide, Andy. I'm Danielle Arrett, the Asfa Yamaru Green and Gold Professor of Global Health at Vermont Oxford Network, the Chief Medical Officer and Director of Global Health at Vermont Oxford Network, and I'll be co-moderating the session today, joined by my colleague, Professor Roger Saul, the H. Wallace Professor of Neonatology at University of Vermont, Coordinating Editor of Cochrane Neonatal, Director of the Vaughan Institute for Evidence-Based Practice. And we are so pleased to have two amazing discussants with us today. Dr. Erica Edwards, a Research Associate Professor at UVM and our Chief Scientific Officer at Vermont Oxford Network, and Professor Liz Rogers from UCSF School of Medicine, the Director of the Roots Small Baby Programs in the Intensive Care Nursery at UCSF Mission Bay. And today's webinar will be sponsored by Vermont Oxford Network and our Institute for Evidence-Based Practice. Professor Saul and Dr. Erica Edwards and I have disclosures for our leadership roles, and we have no other relevant financial issues to disclose. So today's focus is preventing intraventricular hemorrhage. We hope that in the course of an hour together in this session, our web audience will have developed an understanding of the strengths and weaknesses of evidence provided by systematic reviews and meta-analyses, and evaluate how this evidence is incorporated in our practice of neonatal perinatal medicine. I believe that everyone tuning in today is passionate about the end product of this improvement formula, measured performance improvement. To that end, we will cover the two key components in this formula: the generalizable scientific evidence, the so-called do what, or our approach to evidence-based medicine, covered by Professor Roger Saul, and Dr. Erica Edwards and Professor Liz Rogers will focus on the context component, or the do how, highlighting evidence-based practice. We really hope that everyone joining in today, I see 670 and counting, will participate in our webinar, and we have two key ways that you can participate. The first is to chat in questions and comments and to use the drop-down everyone during the presentations and discussions. And the second is to participate in the Zoom polls, which will pop up during the course of our session today. There'll be answers that you can select and click and then hit submit. Unfortunately, if you put your responses in the chat, those won't be aggregated, so please use the Zoom poll to participate. So to give that a try, our first Zoom poll will be where you are joining from today. We'd love to hear all the geographies that are represented by our audience. So we have the 7 continents listed, so please click where you or your team are practicing or joining from, and then hit submit. Just a second for everyone to participate. And you can let us know in the chat. We've tried to be mindful of the time zones and when these webinars are taking place. It looks like 80% of our participants today are coming from North America, but we have 4% from Africa, 6% from Asia, 7% from Europe, and 3% from South America. And we're so excited to have our global audience joining in together. And now to get focused on the clinical topic of today. This is a select all question. We're interested in if you already have written guidelines for any of the following: antenatal steroids, deferred umbilical cord clamping or delayed umbilical cord clamping, surfactant administration, prophylactic indomethacin, or midline head position. So you can select 0, 1, or up to 5 of these clinical topics for guidelines that you have written and available for your team for standardized practice. If you're joining as an individual, you can select what's used in your unit, or if you're joining as a team, we'd love to have your participation. We recognize that some people are joining personally at home and some are sitting around a room with their whole team members. And we'll be excited to take these answers into consideration in the Q&A section at the second half of our time together. Wow, this is great to see. So 80% of our audience already has a guideline on antenatal steroids, close to that, 76% on the delayed umbilical cord clamping, just over 80% for surfactant administration, 29% for indomethacin prophylaxis. So that'll be interesting to discuss, and 67% for midline head position. So thank you so much for participating and giving us some information to include as we get into the discussion later on. All right, so with that in mind, I'm going to turn over the virtual podium to my dear colleague, Professor Ruddersall.
Thanks, Danielle. I'll take the opportunity to first discuss some of the interventions that have been tested to try to prevent intraventricular hemorrhage. First, we have to understand how incredibly immature the brain of the preterm infant is and susceptible to many injuries. The National Institute of Health's neonatal network has published data regarding the trends around neurodevelopmental impairment in extremely preterm infants. What we see is disappointing. The NIH network reports the decreases in mortality that we're all aware of, but it reports a persistent incidence of developmental impairment that has changed little in the past few years. How do we assess neurodevelopmental outcomes? Well, there are many, both short-term and longer-term outcomes that we want to look at. Short-term, we might consider retinopathy of prematurity, seizures, etc. Longer-term, we might consider survival without neurodevelopmental impairment, visual impairment, and cerebral palsy. But today, we're going to specifically focus on the acute injury in preterm infants of intraventricular hemorrhage. And then we have to think, what are the wide variety of interventions that may prevent intraventricular hemorrhage in this vulnerable population? And we'll get to some of them today. It's important to note that, unfortunately, like neurodevelopment in general, the rates of IVH have changed little over the past decades. That is true for any grade of IVH, but unfortunately, it's also true for severe IVH, grades 3 or 4. We see a close to 25% incidence of any IVH in very low birth weight infants, and slightly over 10% incidence of severe hemorrhage in this population. The origins of germinal matrix intraventricular hemorrhage are multifactorial, complex, and heterogeneous. The exact cause is not fully understood, but several factors are believed to contribute to the development of intraventricular hemorrhage, including the fragility of the blood vessels, variations in cerebral blood flow, immature autoregulation, hypoxia and ischemia, fluctuations in blood pressure, and inflammations and infection. And you've seen me use this slide when it comes to pathology like necrotizing enterocolitis, that in fact, the more causes we posit contributing to an important outcome, it may be inversely proportional to our understanding of the process. Now, I think that's more true in NEC than it is in IVH, but I do think we have to recognize that the more causal pathways there are, the more potential treatments we have to consider, and in fact, the less impact each individual treatment may make towards decreasing IVH. The idea of intraventricular hemorrhage was well understood decades ago, but mostly from post-mortem findings, until Luann Pepil did her work with CT scans showing the prevalence of these findings. Our grading system still derives from her original work, and although has been criticized on various levels, is the standard that we tend to use and the one that I'll use in discussing outcomes in this talk. What we see here on this slide is a normal coronal brain view. So the baby is looking at us at the screen, and we see the lateral ventricles and the germinal matrix. A grade 1 bleed, the hemorrhage is confined to the germinal matrix. With a grade 2 bleed, there's intraventricular extension involving less than 50% of the ventricle. When we speak of grade 3 bleeds, we're talking about extension of hemorrhage into a dilated ventricle and blood involving greater than 50% of the ventricle. And lastly, and the most serious grade, grade 4, is extension of hemorrhage into the surrounding parenchyma. Now, the pathophysiology of grade 4 may be very different than the pathophysiology of grades 1, 2, and 3 hemorrhage. And it merely may be caused by venous drainage obstruction and bleeding into the surrounding tissues after venous infarction. And so we have to remember that what might impact on grades 1, 2, and 3 may in fact not affect grade 4, and or that independently there are interventions that may impact on grade 4 that really are not related to decreasing the earlier grades. When we think about the treatments of IVH, there's a very narrow window we have to consider. Well over half, 62% of the bleeds occur within the first 24 hours of life, 48% in total in the first 0 to 6 hours of life. And so we have a small window to consider when treatment should occur in order to prevent hemorrhage. People debate the impact of hemorrhage on longer-term neurodevelopment. Here's some work from the Australian group taking a look at their outcomes. And I think it's important to see on the far right the huge increase in the odds of moderate or severe neurosensory impairment, CP, MDI or GQ less than 2 standard deviations, blindness, or hearing loss. And we see 5 to 11 to a twofold increases in these important outcomes. It's not that we don't see them in grades 1 and 2, and we debate how much impact those lesions have on development, but they are nowhere near as serious as the grades 3 or 4 hemorrhages. So for this talk, I took a look at all of the Cochrane reviews that might impact on intraventricular hemorrhage. And in searching the Cochrane database, there were about 80 reviews that showed up, perhaps about 40 that were worthy of discussion, but clearly we're not going to get to them today. And so what I've chosen are the greatest hits from the Cochrane database regarding what might or might not impact on intraventricular hemorrhage. Recognizing that window to prevent hemorrhage is so small, and so many of the infants have these bleeds in and around the process of delivery, it's no surprise that some of the most important interventions we need to consider are antenatal interventions. The first that comes up, and probably the foremost, is the use of corticosteroids for women with expected preterm labor. We know that corticosteroids stimulate the maturation of alveolar type 2 cells to produce surfactant and elicit architectural maturation in the fetal lung. They do more than that, though. Much of the original work showed that they mature all organ systems. But whether it's because they help with the cerebral vasculature and the stability of that, or whether they simply make the infants less ill and therefore more stable and less prone to problems with autoregulation and cerebral fluctuation is unclear. But this is a powerful drug in our armamentarium to prevent IVH. Many of you are familiar with the meta-analyses and systematic reviews. Here's the one from Roberts in 2017, a huge number of trials, 30 trials, over 8,000 infants. And when we think of the results of these trials, we all think about the impact on RDS and neonatal death. And we know that it virtually cuts those risks by 40%. That probably is the driving force for why we use antenatal steroids. But we forget that there's actually more good to this therapy than we recognize. 16 trials report on intraventricular hemorrhage. representing a 45% decrease in the risk of any hemorrhage. The statement from the NIH is very strong about our need to use steroids and that they will result in substantial decreases in morbidity and mortality. But they don't actually address some of the downstream issues, in part because the data wasn't there. What about neurodevelopment? Well, there are really only a few trials from the original randomized controlled trials that report on neurodevelopment. And when we look at this intellectual impairment in childhood, we see a very imprecise response that suggests there could be harms or benefits associated with antenatal steroids. So we have to look a little further at other literature that will help support whether or not we see downstream benefits from this. Again, we'll turn to the National Institute of Child Health's neonatal network and work that was done by Wally Carlo and Associates on the association of antenatal corticosteroids with mortality and neurodevelopmental outcomes among our most vulnerable infants born at 22 to 25 weeks gestation. Predictably, we see changes in death or developmental impairment, but we see alone significant decreases in neurodevelopmental impairment, a 10% decrease, an odds ratio that suggests a 17% decrease in NDI. Steroids have been widely chosen now as a therapy. We know that well over 80% of infants receive them. So in some ways, why discuss them? And the fact is there's still a pretty large gap between infants who are inborn and receive adequate antenatal corticosteroids and infants who are outborn, pointing us towards a potentially important quality issue in our management of these babies. Now, I'm going to digress for a second and choose a drug that we all think about in terms of neuroprotection and ask whether or not it in fact affects intraventricular hemorrhage. And again, we're in the antenatal realm, and we're looking at magnesium sulfate for women at risk of preterm birth. This is, of course, a very interesting set of trials. There are few trials, 5 trials, but a huge number of women, over 6,000 women. And so we have very precise estimates. And we do know from this that there are meaningful decreases in cerebral palsy suggested from the data. We see a typical relative risk of 0.68 and a confidence interval that's very narrow. But we also know, because cerebral palsy is relatively rare, that it takes a lot of women to treat to even think we're going to begin to accrue this benefit on cerebral palsy, with a number needed to treat of 63. But then the question is, what are the mechanisms for this neuroprotection? And apparently, it's not prevention of intraventricular hemorrhage. Okay, there is no change in either any intraventricular hemorrhage or severe intraventricular hemorrhage. So this is a different mechanism of improvement that we see with magnesium sulfate, probably related at a cellular level rather than the level of intraventricular hemorrhage and other injury. From a quality perspective, both magnesium sulfate and antenatal steroids have very similar indications, and yet our use of magnesium steroids lags significantly behind our use of antenatal steroids. So one would think that this is also a potential quality improvement, even though we shouldn't expect it to decrease IVH. What about other antenatal studies? Again, since that's where the gold is in terms of our interventions, what else has been done? And there's been some very straightforward, interesting studies of using vitamin K prior to preterm birth and phenobarbital prior to preterm birth. In the case of vitamin K, we see that there are 8 trials, relatively small, involving only 843 infants. And we see a small suggestion of decrease of severe hemorrhage in these trials. For phenobarbital, we see a decrease in any hemorrhage and severe hemorrhage in the 9 trials that are reported. So why aren't these 2 therapies embraced? Well, there are serious questions about the methodology of the trials included in both of these reviews. In the vitamin K review, there's an issue of the trustworthiness of the data. In the phenobarbital review, There is concern about methodologic issues. If you subtract the quasi-randomized studies and the less trustworthy studies, you don't get such a strong response. And some of the bigger and better done studies do not show such a response. So neither of these therapies has been picked up as a potential treatment that we should pursue. So now let's move on to the delivery room. Again, an important point because it's in that narrow window where we might impact on IVH. And I've picked out one important intervention that stands out in our delivery room management, and that is the umbilical cord management and the issue of delayed cord clamping versus early cord clamping. Now, you know there are myriad different approaches, but this is the classic approach. Delayed cord clamping in this review being defined as anything over 30 seconds, and early cord clamping, the immediate clamping of the cord at birth. And what we see is a small difference in any intraventricular hemorrhage, with 15 studies looking at over 2,000 infants. The point estimates suggest a 17% decrease in the risk of any hemorrhage, and we see that it is broad and may include very small improvements. What we do see when we follow on with these studies is that there are some positive effects downstream in terms of development in these infants. Here is work from the large APPS trial looking at death or major disability at 2 years corrected age amongst infants enrolled in the trial. We already knew from the trial results that there was a meaningful decrease in death from 11% down to 8%. But what we didn't know until this follow-up was that there was a trend towards improvement in disability. But when we look at death or disability, we see a very significant improvement associated with delayed cord clamping. When we add that work to the meta-analyses of other trials that looked at developmental impairment in early childhood, we see that there is now a borderline proof that it probably reduces death or severe disability in preterm infants who receive delayed cord clamping. So now we're moving into the interface between the delivery room and our postnatal stabilization. And the big question there is whether or not our use of surfactant in any way, shape, or form decreases intraventricular hemorrhage. Multiple reviews have been done back in the 1990s, early 2000s. We know that there is a profound decrease in pneumothorax, whether we use the surfactant in a prophylactic mode in high-risk infants, whether we treat infants with established RDS. We also know that there's a decrease in mortality associated with surfactant treatment, no matter which approach we take. If you had told me that you had a drug that was going to decrease RDS and decrease pneumothorax, I would have told you you have a drug that will decrease intraventricular hemorrhage, but you don't. Okay, there is no effect reported on intraventricular hemorrhage, in this case severe intraventricular hemorrhage, with any of the early surfactant trials. And when we compare the two approaches, surfactant given prophylactically versus surfactant given as a treatment regimen, we also see no effect on intraventricular hemorrhage. So is there anything that we should consider regarding the use of surfactant and IVH? And perhaps there is. More recent trials looking at our methods of administration and our ability to keep infants off of mechanical ventilation have shown that there may be some advantages, not just in death or bronchopulmonary dysplasia, but also in intraventricular hemorrhage. Looking here at the review from Abtil Lutif and others looking at thin catheter administration of surfactant, we see there's now a fair body of evidence, 16 trials involving over 2,000 infants. When we look at the meta-analysis of thin catheter administration, either directly against Ensure or against a more selective strategy, we see a decrease in the risk of severe intraventricular hemorrhage, which might be, the point estimate says 48%, but it might be as much as 58% or as little as 4%. In either case, a very promising approach. So now let's talk a little bit more about postnatal interventions. specifically prophylactic intravenous indomethacin for preventing morbidity and mortality. This is a hot issue when it comes to any of our efforts to reduce intraventricular hemorrhage. There are 19 trials involving 2,872 infants. Many of these trials were done with an eye towards simply preventing PDA, but some, in fact the largest, such as the TIP trial, were done quite purposefully to look at the impact on IVH. We know from the trials that prophylactic indomethacin has a very strong effect on any of our markers or outcomes related to PDA, whether it's appreciating any PDA murmur, a symptomatic PDA, or the perceived need or requirement for PDA ligation. We know that prophylactic indomethacin profoundly decreases that. The pleasant surprise in the data was that there was a decrease in any hemorrhage, and particularly in severe hemorrhage. We see a decrease that's compatible with a 5% absolute reduction, suggesting that for every 20 infants we treat with prophylactic indomethacin, we'll see one less infant who has a severe IVH. We don't see other problems related to ischemia, including an increased rate of periventricular leukomalacia. In fact, it's decreased, or other signs of white matter injury. But here's the problem. When we look at some of the superb studies that have been done, particularly the TIP trial at follow-up, we don't get any message that downstream this affects issues like cerebral palsy or neurodevelopment. This then becomes an issue of values. Where do we place IVH in this hierarchy of what matters? And certainly here's just a diagram looking at the critical importance of the decision. We would all agree that a PDA murmur is a trivial issue, so any PDA doesn't matter. PDA ligation, we might argue, isn't a necessary treatment and is very center dependent. Severe IVH creeps up there, though, for what most of us would agree is an important outcome. But it is superseded by death and developmental outcome, and we don't see those differences when we think about prophylactic indomethacin. So it leaves us with the idea of, is this glass half empty or is this glass half full? Now, the fact is that the majority of us are not using prophylactic indomethacin. And so most of the caregivers have decided this glass is half empty. But I know from work worldwide, in Canada and in Saudi Arabia, that parents view this very differently, and that they think that these are advantages and outcomes that perhaps they would like to see accrued for their infant. And so it makes us rethink this issue of our use of prophylactic indomethacin. I could go through all the other studies, but the fact of the matter is there are no other studies of PDA management that report a decrease in IVH. So that includes trials of ibuprofen, paracetamol, that includes surgical ligation, and trials of various aspects of timing. And so really only prophylactic indomethacin is the one to think about when it comes to a cyclooxygenase inhibitor and treatment of PDA. So now we've got a very popular one with very little evidence behind it, and that's the issue of headline position for preventing occurrence or expansion. And this has gained a great deal of popularity. Perhaps the idea that less handling, less perturbations of cerebral blood flow, etc., will be a good thing for these babies. But although there are several observational studies, there are only 3 trials involving a handful of infants regarding this. And in those 3 trials, they compared a variety of different head midline positions. What they found was little impact on any hemorrhage or severe hemorrhage, although there was, interestingly, a slight improvement in survival. The certainty of the evidence is very low because of the limitations of study design and the imprecision of these estimates. There's a litany of other therapies to consider. Postnatal phenobarbital, ethamsulate, an agent that is used to improve platelet adhesion, vitamin A, vitamin E, and early EPO that have all reported on and shown some glimmer of hope regarding IVH. That said, ethamsulate, being perhaps the one with the strongest results, is never used, and research on that has lay fallow. Vitamin E, although there's some small effect, had counterbalancing concerning effects, particularly regarding sepsis. The others, such as vitamin A, show little result, and so there's not a lot going on with these other agents to make them think that there's great promise in their use. I'll end with this issue from work by Steve Miller and his group regarding the association of socioeconomic status and brain injury, more to prove the point that having an IVH is not in and of itself going to absolutely lead to longer-term problems of neurodevelopment, and to give a boost to the idea that all the issues of family support and follow through are critically important. This is work that many of you have seen. It compares three sets of families who have only primary or secondary school education, families with some undergraduate education, and families with postgraduate diseases. Here we see the predicted IQ, and we see the huge difference in the infants who had IVH, okay, versus who did not. Here, for the families of better means and education, the difference narrows, and it's almost imperceptible when we come to those families that, based on education and perhaps economics, clearly have more advantages in how they treat their child post-NICU discharge. Bringing up the issue that the social inequality has to be addressed if we are to not prevent IVH, but prevent the consequences of IVH. The future, of course, who knows? It may be bright. There may be issues like stem cells, but that's a review of the known interventions that we can use antenatally and postnatally to prevent IVH. So thanks, Danielle. I'll throw it back to you.
Thank you so much, Roger, for setting the stage of evidence-based medicine and fueling the start of our chat conversation. We'll now transition into evidence-based practice, and to lead us off is Dr. Erica Edwards, in which she will shed light onto QI interventions to reduce IVH in preterm infants. Thank you, Erica.
Thank you, Danielle. I'm going to address the question, can quality improvement interventions reduce intraventricular hemorrhage in preterm infants? We did a systematic review of the literature for interventions that had as their primary focus reducing the incidence or severity of IVH in preterm infants. Interventions that included IVH as one of several morbidities targeted were not considered. We excluded studies that did not meet our definition of quality improvement, that had a population focus outside of neonatal critical care, where secondary analyses of previously published initiatives were abstracts only, or that included IVH only as a balancing measure. We used a definition of quality improvement suggested by Marjorie Dance and colleagues, which was an effort to change or improve the clinical structure, process, and/or outcomes of care by means of an organizational or structural change. As a result, the interventions that we chose to include in this review ranged from reports on the introduction of a new protocol or an intervention bundle to those that use sequential learning and traditional quality improvement methodology. Our search strategy was taken from a publication by Suzanne Hempel and colleagues, who tested a variety of search strings. The one that we chose was the best case strategy with the highest face validity. We did the search on intraventricular hemorrhage and looked at the citations for the interventions that we chose, upon which we discovered that people also use the term intracranial hemorrhage, so we did a second search using that term. We searched PubMed, Embase, and CINAHL, which indexes nursing and allied health literature, through March 16, 2023. To assess the interventions, two reviewers applied the quality improvement minimum quality criteria set, developed by Suzanne Hempel and colleagues. The QI-MQCS domains were selected by a stakeholder panel and represent core aspects important to quality improvement. The 16 domains were operationalized and psychometrically tested to develop a reliable and valid assessment. These domains are meant to assess the quality of the intervention as represented in the publication. The database searches retrieved 279 articles. After applying the eligibility criteria, 237 records were screened and 203 records excluded. Reviewing the citations of the 33 records selected for review identified 9 additional records, of which 4 were included. Overall, 37 full records were reviewed, of which 17 were selected for inclusion. Of the 17 interventions, 10 took place in the United States, 2 in Germany, 2 in Brazil, 2 in Canada, and 1 in the Netherlands, and included 5,481 infants, 2,347 in the pre-intervention groups, and 3,134 in the intervention groups. Inclusion criteria were not standardized and were based on gestational age alone, birth weight alone, or both. Of the 15 interventions that had exclusion criteria, most excluded infants with congenital anomalies or early deaths. But again, exclusion criteria were not standardized either. Nearly all of the interventions included actions in the antenatal, delivery room, and NICU periods, except for 2 that focused on the delivery room period only. The number of clinical actions in each intervention ranged from 1 to 42 or more. There were 6 unique citations that mentioned actions in the antenatal period, and all of them included exposure to antenatal betamethasone, as Dr. Saul discussed in the previous segment. The other antenatal measures started a theme that was continued in the delivery room and NICU staffing sections, that the most highly trained individuals and centers should be responsible for caring for infants at risk for IVH. There were 14 unique citations that mentioned delivery room actions. 9 included avoiding hypothermia, and 9 included cord management, as mentioned by Dr. Saul. Some of the interventions also set the stage for actions in the NICU period, including midline head position and avoiding light exposure in the delivery room. There were 6 unique citations that mentioned parental engagement, and only 1 that included parents on the multidisciplinary team, that of Dr. Rogers, our discussant in the next segment. The interventions had conflicting advice around skin-to-skin care. 1 intervention encouraged skin-to-skin in the first 72 hours, 1 limited it, and 2 avoided it. 2 advocated for touching if unable to do skin-to-skin, and 1 intervention encouraged parental instruction and involvement in care. There were 11 unique citations that mentioned staffing, most referring provider trainings. However, there was a theme around the most experienced physicians and nurses caring for patients, especially in the first week after birth. 1 intervention referred to it as the Golden Week, with specialized teaching modules and nurse practitioners. Additionally, 1 set of interventions identified variability in cranial ultrasound practices and interpretation between centers, and developed 5 potentially better practices related to cranial ultrasound evaluations. 11 interventions mentioned the environment, and all 11 included noise reduction, while 9 include minimized light exposure. 2 units developed specific small baby areas. One of those units was the University of California at San Francisco, where Dr. Rogers practices. So hopefully we will get to hear more about that small baby unit when we hear from her. 14 interventions mentioned infant positioning, and all 14 included midline head positioning, despite the lack of evidence as described by Dr. Saul earlier. 11 also mentioned elevating the head of the bed, but there was no consensus on how much to elevate. 14 interventions included actions to minimize handling, and there were 34 actions in this group. Many of those actions were quite specific. This list includes the ones that were mentioned most frequently, but most boiled down to the same thing: minimize interactions with the infant, and when interaction does take place, do it carefully, consistently, and mindfully. 11 interventions mentioned medications, but only 6 included indomethacin prophylaxis, which Dr. Saul reviewed earlier. In protocols and procedures, there were many mentions of standardization, new protocols, EMR order sets, and handoff tools. Many units also used reminders in the delivery room, on incubators, on the admission board, and on doors of single-family rooms. To summarize intervention effects, we calculated risk differences using data extracted from the interventions that published the raw numbers or proportion of infants with outcomes. We report unadjusted risk differences with 95% confidence intervals and produced forest plots using RevManWeb. 4 of the 10 interventions that reported data on IVH had significant unadjusted risk reductions. No studies significantly increased incidence of IVH. 8 of the 13 interventions that reported data on severe IVH had significant unadjusted risk reductions. Again, no studies significantly increased severe IVH. The median QI-MQCS score was 11 out of 16. 10 interventions received scores of more than 10, indicating high quality. 6 received scores of 7 to 10, indicating medium quality, and 1 received a score of less than 7, indicating low quality. This plot shows the specific score for each of the 14 interventions that were included in the forest plots, ranked by QI-MQCS score and stratified by whether there was a statistically lower risk difference. The findings that I've discussed have some limitations that apply specifically to this review and some that apply to systematic reviews of this type generally. Most of the interventions that we reviewed had many actions, and it was hard or nearly impossible to identify exactly which action had an effect. Additionally, it is hard to measure the effect of doing quality improvement, identifying a problem, coming together as a team, reviewing the evidence, from the effect of doing the intervention itself. Second, the limitations that apply to systematic reviews of QI, these types of reviews are increasing in number, and all will need to grapple with publication bias, teams not publishing quality improvement or not publishing negative results. The definition of QI that we used for this review was purposefully broad. It overlaps with some definitions of improvement science and implementation science. However, the search strategy that we utilized was not intended to discern between these fields. Incorporating implementation science into the search strategy, or using a less broad definition of QI, could be considered for future reviews. Finally, existing tools for assessing risk of bias do not address the unique characteristics of QI. GRADE is the current standard in the practice of evidence-based medicine for assessing the precision and certainty of evidence, but reports of interventions that are not randomized trials would likely always be rated as low or very low quality. We need new tools to assess bias in QI reports. In conclusion, several interventions demonstrated reductions in the incidence and severity of IVH in preterm infants. Given the heterogeneity in the interventions and the QI methodologies used, and the variation in the quality of the reports, it is unclear which actions are responsible for the improvements. It is also unclear how differences in NICU culture affect the effectiveness of the QI efforts. Despite these shortcomings, teams at units with data indicating opportunities to improve the occurrence of IVH and severe IVH should consider adapting interventions identified in this systematic review for their local context, testing them using rigorous QI methods, and publishing the results so that others may learn from their efforts. And now I'll pass the discussion back over to Danielle for next steps.
Erica, thank you for your insight into QI interventions to reduce IVH, which both is an amazing body of work and has led to a robust number of questions in the chat. So let's turn to a poll to see amongst our audience today, who can report that their center has participated in any QI initiatives with a specific goal of decreasing IVH. We've listed 3 options: yes, no, and unsure, leaving room if participants are unsure of the specific focus of a unit's QI project, or if they're unsure if the approach to their project was consistent with quality improvement, as opposed to simple practice changes with good intent. It's amazing that we have over 1,100 participants joining in today, so I can't wait to see how many team members are engaged in specific QI interventions. It looks like just over half. So we have 51% have done a specific QI initiative focused on reducing IVH, a third no, and 16% unsure. So thank you for that honesty. And moving on, as an exemplar of bringing the QI approach to IVH reduction in preterm infants is Professor Rogers and her multidisciplinary team at UCSF. So I'll turn the microphone over to Liz and invite her to share her experience with our group today.
Thanks so much to Danielle, Roger, Erica, and the whole Vermont Oxford Network for inviting me to share our specific experience in our efforts of trying to reduce IVH in our organization. So we are very lucky, those of us who contribute to the VON data set, to have data available in Nightingale. I also work in California, and so have the ability to use our California Perinatal Quality Care Collaborative benchmarking to look at key quality indicators of care over time. So this really emphasizes the importance of using data to drive improvement efforts. And what many of you at the bedside may notice is what we noticed in 2014 in our work, that we were experiencing a trend of increased severe IVH compared to previous years in our care practice. We then confirmed it with our benchmarking data through our CPQCC network, then worked to convene a multidisciplinary group of concerned and interested folks to design an improvement initiative to reduce this incidence of severe intraventricular hemorrhage for our preterm infants. This resulted in what we called our PREME project, and over 50 participants, nurses, physicians, respiratory therapists, dietitians, and importantly, parents, contributed to a process to consider the most important local drivers of IVH in order to reduce them. And what started as a fairly focused data review revealed, of course, as you've heard from Roger and Erica, that there is no silver bullet that prevents IVH for all preterm infants. And therefore, multi-system tactics would be necessary. And that resulted in this wide-reaching driver diagram, identifying many potential targets and many potential interventions to reduce severe IVH. And so while we were looking for an easy IVH reduction bundle, what really resulted was an 80-page document with an overarching philosophy of precision in our care and recognition that all aspects of care, respiratory, cardiovascular, hemodynamic, and importantly, developmental, impacted the developing brain. So in short, that all care is brain care. We did implement this 80-page sort of philosophy of care with support from our hospital administration and leadership. We trained everyone who interacted with our patients, including radiology and echo techs, in addition to our nurses, physicians, nurse practitioners, fellows, trainees, et cetera. And this resulted, oh, excuse me. This resulted in a reduction in IVH and a huge success of our PREME project, whereby we had a rate of 12.5% in 2014. By 2019, we had achieved no severe IVH. And this was maintained. We had no severe IVH in our unit for 2 years and 3 quarters. And while that rate is no longer 0, it remains well below the goal we set for ourselves and benchmarking ourselves with similar units across the country. So you can see here the result of monitoring and watching the data to ensure that we were having the impact we set out to have. And I want to say that importantly, our little PREME project completely changed our philosophy and culture of care for these infants and led to the creation of our small baby unit as a way to really carry out a different culture of care, and in an effort to sustain the improvements we achieved, but acknowledging that systems can contribute both to IVH and to other types of acquired brain injury or maldevelopment. So importantly, we need to continue to measure impacts of system and culture of care, as Erica mentioned. So I'm going to pass it back so that we can have more time for robust discussion and hope that our example can be one way that you can consider how to use all of this data and adapt to your local context.
Thank you so much, Liz, for sharing that amazing work with us. Looks like we have about 8 minutes left for open discussion, comments, questions from the chat, and audience engagement. So if you haven't yet, I just encourage everyone to participate with the chat. You can see on the screen here how to do it and select it so that everyone can see. And I'm going to see, I think Roger has been reading all of the very many messages as they come in. And if he has the first comment question to pose to the group.
So that was great. I mean, one of the first questions that came in after my talk was, what about QI? And Erica, thank you very much. And I think that's a really important part, particularly of these presentations, where we want to link what's going on with the evidence and QI. I'm going to briefly answer a couple of questions and then ask a question myself on this. We had lots of other interventions mentioned about, well, what about the impact of? Let me briefly go through it. In terms of delivery room management, people asked about cord milking as compared to cord clamping, delayed cord clamping. Milking has a bad reputation in the extreme preterm, less than 27 weeks. The excellent studies from Anoop Kathiria and colleagues have gone on to study the larger babies, but that really remains unclear. And cord milking may, in fact, with the volume shifts, contribute to IVH. So when we speak of delayed cord clamping, we're specifically talking about a timing or physiologic measure. There was a question also antenatally about differences in steroid preparations for antenatal steroids. There's no differences reported between beta and dex. Volume expansion was mentioned in the chat. There is no change on IVH associated with it, even though there was one study, the Beverly study early on, that did support that. There's no evidence from that. Other interesting questions about ventilator management, volume targeted. There is no change in IVH, but there may be a signal towards PVL there. And permissive hypercapnia, which seems very appealing, did not report any changes. So that's a quick overview from some of the questions there. But my biggest question really is for Liz and for Erica. There is a disconnect between the small evidence that we have from trials and what people actually do in quality. And I have some thoughts on it myself, but I'd love to hear you guys discuss that.
Go ahead, Liz.
Yeah, I think that's true. And I think we talk about, unfortunately, when we review the data, we often look at one intervention and the impact of it. And it's hard to really consider bundled interventions. And we also know that local contexts really drive those what's contributed in a particular local bundle. And so how do you generalize the outcomes of a packet or a package of interventions? So I think that's a really challenging thing for us to do that we need to figure out. We need to figure out how to measure the impact of bundled care. So that's, I think, my first thought on that. I
also think from looking at the interventions that people seem to build on what others had done. I think that there was a lot of mention in each of the articles about how we reviewed the evidence and other intervention. And so if everybody else is doing midline head positioning, then maybe I should too, sort of thing. But for me, I think that the idea of midline head position, it goes back to this idea that we're being very mindful and we're being very conscious and very, when we're caring for the baby, when we're positioning the baby, and it's so hard to measure that NICU culture piece.
Yeah,
So,
no, I
yeah.
agree with that.
And I agree, Erica. It's interesting to me that although the trials that the quality improvement studies that you reported focused on prevention of IVH, they intelligently said, well, okay, that's one part of improving development. It seemed like they linked optimizing development and preventing IVH, and many of the things that you went through. I mean, just look at the time frame, which I discussed about when IVH occurs. And it may well be as much about preventing the consequences of IVH and improving development, which of course I think you'd be foolish if you're doing quality improvement not to bundle those two concepts together. And then on midline head, I'm very confused. There is a quality of care and mindfulness that I respect. There is some limited rationale, but there is an opportunity cost. And the part of me that does not want to make parents feel your baby's so fragile that you can't touch, hold, whatever, and whether that extends past that period and the price parents are paying for this does concern me in terms of the adaptation of that one thing. But I sort of get it as a general statement to your staff: be careful, be mindful. And that's true about the sound issues you mentioned, Erica, noise, and other aspects there.
Yeah, I want to emphasize the midline head position. It always comes out in questions. And I think just as you presented, Roger, there's no significant evidence, but like many of the things we're talking about, there's evidence-based practice that we all want to utilize and perform. But there are some common sense interventions that we need to consider. And I think early skin to skin has shown more benefit for both short and long-term outcome for infant and family. And so if you have another intervention that is not well supported by the evidence, that is inhibiting your ability to provide another evidence-based practice, that's when you really need to consider how these things are at odds with each other. And so as I saw in the chat, and I will reiterate, skin to skin beats out midline head position every day, any day. But if it's conveniently performed while baby's in an incubator, fine, but don't let it reduce or become a barrier to you performing skin-to-skin care or other evidence-based practices.
Yeah. Ron Kleiman wrote in about his Pindo trial, which is almost the opposite of what I just discussed. Far from bundling too many things, it really isolated prophylactic indomethacin as a possible quality improvement initiative and did not report positive findings. So I think he worries that all studies have a shelf life, and whether or not aspects of care have moved further ahead, that this use of prophylactic indomethacin may or may not be as impactful as the trials I presented.
And I will acknowledge that I have the great benefit of working with Dr. Kleiman in my institution. And so we absolutely use data to help drive. And just like we used selective indomethacin prophylaxis in the era that I described and that has been published in our paper in pediatrics, we have actually gone away from it at this point and am currently, doing ongoing measurement to see whether there is any impact in our population.
I see we're nearing the top there. I'm going to throw one last question in, and all the points have been so excellent. I'm going to kick it back to Roger. We have evidence-based practice and some common sense interventions that we all have our hearts into. I'm curious if you feel like there are still any gaps for those that are listening today and they have heard Erica's point about publication bias and encouraging us to publish our QI. Do you feel like there are some areas where we as a community should be looking to publish more on, such as skin-to-skin immediate kangaroo mother care?
You said it all right there. First, though, I really do think that this, and I'm so happy with this session, with Erica's contribution and Liz's contribution. We need to link what we're actually doing with these interventions and report back to each other what's working, what's not working, and beyond how we did the intervention. I see in the chat exactly what you do for midline. I'm not endorsing midline, but I mean, some of the issues there. I do think it's clear, though, if I was to walk away from this, the single biggest impact on IVH would be better teamwork with your obstetric and maternal fetal folks and optimizing that. So much else that we're hearing about is about creating a unit that respects the idea that all care is brain care and respects the teamwork involved in doing that. And there are many individual things in terms of ventilator management. Certainly I heard as one of the issues that might impact, but whatever. I think it's great to hear a thoughtful review of the quality work that tries to move this forward.
Perfect. Well said. Thank you so much, Roger. And thank you to everyone, the 1,100 people who joined in with us today. We're so happy that you joined in and participated in this really important discussion. And we hope to see you again for VON Grand Rounds in November to celebrate our AAP VON Scholars, and in February for a session on the infant and family experience. Our improvement collaboratives called NICU and iNICU have scheduled sessions in September and December for the remainder of this year, focused on acquired brain injuries and equitable care. And if teams joining today are interested in learning more about All Care is Brain Care and our QI collaborative, you can reach out to our VON team to learn more. So thank you, be well, and until next time.
Bye-bye.